everyone, and welcome back to another insightful episode of MedSynapse podcast series. I'm your host, Hetvi Shah, and today we're diving deep into an important and evolving area of oncology, which is redefining care, the advances in the treatment of advanced ovarian cancer. So, ovarian cancer, particularly in its advanced stages, remains a major clinical challenge, but recent years have seen remarkable progress in surgery, systematic therapies, and innovative treatment strategies. And to guide us through these advancements, we are honored to have Dr. Roopesh with us, a highly accomplished gynecologic oncologist with over 17 years of experience. He is among the very few specialists in India performing advanced procedures like cytoreductive surgery with HIPEC and PIPEC. And he is also the first from India to complete the prestigious European School for Peritoneal Surface Oncology Fellowship under ESO. His expertise and contribution to gynecologic oncology are truly inspiring. So, welcome, Doctor, and it is such a pleasure to have you with me this today.
Thank you, Ms. Hetvi, and thank you, MedSynapse, for having me here.
So, Doctor, to just start with the entire discussion today, let's start with like the treatment process. How has the treatment paradigm for advanced ovarian cancer evolved in recent years, and what are the most significant milestones achieved so far?
Well, to answer this very important question, I would just slightly go historically. Ovarian cancer, which is known as the silent killer, is one of the most lethal gynecological cancers. 75 to 80% of ovarian cancers present in advanced stages, and that's the reason we call it a silent killer. And basically, the woman will not get to know any kind of symptoms until it has progressed, only when the disease has progressed. So what does the meaning of disease progression mean in ovarian cancer is that although ovarian cancer is something which spreads heavily, but it spreads mainly loco-regionally, that is all inside the abdominal cavity, across the layer of the abdominal cavity, which is called as peritoneum. So it is one of those peritoneal cancers, like other peritoneal cancers like colon, appendix, gastric, etc. So ovarian cancer mainly spreads peritoneally, and only when the disease burden is quite high and when there's a lot of fluid inside, that's when the woman manifests. So this is the reason it's called as a silent cancer. And historically, as I said, initially the concept was, in fact, there were only two arms of treatment of ovarian cancer, which is surgery and chemotherapy, which also evolved sequentially. So initially, the concept of surgery was you need to remove whatever is possible. So that is what was the initial dictum. But over a period of time, there are a lot of things that evolved that you need to remove so much that you can only leave behind a certain amount of disease, because it may not be humanly possible to remove everything at once, owing to the magnanimity of the disease spread. So later onwards, we have evolved currently to a situation. And meanwhile, even chemotherapy also evolved, wherein in about 2011, there was a major article which suggested that if there is a low probability of removing all the disease together, then better to downstage the disease by giving chemotherapy. Also, in certain women in whom a major surgery is not possible, like those women with comorbidities. So in them also, we may have to downsize the disease, which is done by giving chemotherapy initially. Usually the total cycles of chemotherapy for ovarian cancer is about 6 cycles. So we can give 3 cycles now and then reassess and then do the surgery. So that concept came out in 2011. So after that, again, there was a significant improvement in survivals. See, all these evolution happened because the survivals were pretty low. It was like, said that about 5-year survival of overall survival for a woman was about 37 to 42% only with all these conventional methods. So then came the concept of intraperitoneal chemotherapy, wherein chemotherapy, instead of being given inside the veins, what if it is given inside the peritoneum so that it will act locally and it will have a better effect. So there was one of the studies that showed very positive result, but unfortunately it didn't pick up too well because of a lot of other issues like the port toxicity and infections, etc. So over a period of time, then came the most important thing, which is the HIPEC, that is the heated intraperitoneal chemotherapy or hyperthermic intraperitoneal chemotherapy, wherein after the surgeon completely achieves an entire debulking, which we now actually scientifically call a cytoreduction. So once the optimal cytoreduction is done, so that is when then we can try with the chemotherapy, heated chemotherapy circulating inside. So the concept came out as the maximum debulking or maximum cytoreduction happening by the surgeon, removing everything. That is the macroscopic cytoreduction. And HIPEC would take care of the microscopic disease if in case there were any cells that were stuck here and there during the process of surgery. So they were. So this now in 2018 there was a major trial that came out and suggested that that has a better result. So fortunately for ovarian cancer, there has been fantastic results. And again, there have been other kind of technically advanced procedures like PIPAC, which is pressurized intraperitoneal aerosolized chemotherapy. But again, they are not reserved for the initial line of treatment, rather after failed line of treatment when multiple lines of treatment have been done and when it recurs. So that's when PIPAC can be done. So currently, a lot of trials for PIPAC in upfront also have started, but these are the major breakthroughs evolutionarily that happened for ovarian cancer treatment.
Correct. So the actually, Tawna, I think that really highlights how much the field of ovarian cancer has progressed, and also the advancements has progressed over the years, and hope it brings for so many patients, because as you mentioned, the survival rate was so low initially. So now, doctor, coming to that, how is the role of cytoreductive surgery and HIPEC changed outcomes in advanced disease?
Exactly. So that is the most important thing. Like as I told you, the initial surgery was remove as much as possible, but later onwards, remove maximally and leave behind only very small amount of disease. Initially, it was like even if you leave behind 2 centimeters of disease, one single major focus of disease, also it was okay. Later on, that was divided to 1 centimeter of disease. But now, currently, HIPEC surgeons, we believe that there should be no residual disease that should be left behind inside the peritoneal cavity, or maximum even if there is a necessity that is on a major viscera, major organs such as major vessels or somewhere. Yeah, so that time you may not be able to kind of take it out. So you can still, if leaving behind 2.5 millimeters of disease, even that is enough. So we call it as optimal cytoreduction. So our goal is to ensure an optimal cytoreduction, whereas we're gonna leave behind any disease. So with this concept, after cytoreductive surgery came up, so of course this needs a lot of surgical training. It's not just the conventional training what we learn in our training programs and our fellowships or in our postdoc training programs, but it's also we need to scale up our learning skills, and probably that is one of the reasons why what inspired me to get into the European School of Concept was oncology, which is a very structured program. So currently, yeah, we choose our cases well, and you're gonna take on those cases wherein you'll be able to remove. If not, you will give chemotherapy, downsize, and then do. So after CRS came, this kind of cytoreductive surgery and HIPEC came, the survivals further improved to almost 68%, 5 year survivals, which was about 40 roughly. So it significantly leaped up. So this is one of the very big improvements. So I personally have my own patients who have been doing well for quite a long, the longest survival is about 10 years. So of course, it's not just surgery is one of the very important parameters, a good surgery, which ensures a good survival. But apart from that, there are also other important criteria such as the biology of the disease, what type, what subtype, or even the genetic mutations like BRCA, or we have something called as a homologous recombinant deficiency, the HRD pathway. So there are multiple things now of late based on which the overall survivals depend upon. But yes, all said and done, essentially a very good surgery is something which goes as a rule. So that is something. And of course, HIPEC is something which needs to be very judiciously used only when a complete cytoreduction is done, as per the norms. But if there is a significant amount of disease left behind and if a HIPEC is done, it will not help. So we always say that a good CRS is better than a bad HIPEC, but a good HIPEC is never better than a bad CRS. And also, so that's how it is.
Very much, and it's really important
Exactly.
even know these skills so with precision. So it's really important for these surgical innovations, and I think these surgical innovations are also transforming patient outcomes overall. So now, Doctor, could you elaborate on the role of PRP inhibitors, angiogenesis inhibitors, and other targeted agents in managing advanced ovarian cancers?
Yeah. So, as I told you, the two mainstay of treatment in ovarian cancer has always been surgery and chemotherapy. So, it's like a combination of both is what ensures the best survival. So, why do we worry about ovarian cancer and other peritoneal surface malignancies? Is because how much ever you treat, they are bound to recur. So, that is something which should never happen because, the surgeon feels bad. But unfortunately, that's the rule. They do recur. So that is the reason a lot of innovations were tried specifically molecular aspect wherein first one of the earlier discoveries were of the VEGF inhibitor, which is basically the vascular endothelial growth factor inhibitor, the bevacizumab, which is widely used in many other malignancies as well. So it is basically that targeted therapy which cuts off the blood supply to the tumor cells. So the usage of this, especially initially it was studied in the adjuvant settings as well as the recurrent settings. So we have good data for all that. Uh, uh, so that was found to have a significant improvement initially. This way back in 2010, 2011, somewhere around that time. It is when the the late 2009 2010, that's when like the bevacizumab role got a big impetus. And later onwards, there was a study of these PARP inhibitors, so the polyadenosine triphosphate inhibitors. So they are basically they target particularly this pathway wherein the patients, when they are homologous recombinant deficiency pathway, the HID pathway, uh, what is that? Basically, we send the tumor for testing of HID testing. So, especially when the HID testing is positive, or even when the germline testing is positive, that is when the patient is BRCA positive. So, in these are those kinds of patients in whom the PARP inhibitors are very useful. So, again, addition of PARP inhibitors has again increase the survivals. Now, in fact, we in certain categories of patients, we even speak of 10-year survivals. So, which was earlier when we used to speak of 5. So, there have been fantastic results. I mean, of course, all said and done, ovarian cancer does relapse, but the time to relapse is something which matters. So, a cancer that relapse after all the initial treatment within 6 to 12 months is a bad cancer. I mean, to say it's almost a platinum resistant cancer. So, but that is a chemotherapy resistant cancer. So that they are those kind of category of patients. But there are certain people who don't recur after many years. So they are one of the good responders. So current data also suggests that many of the BRCA positive tumors do well, and sometimes even for HIPEC they are favorable. So there is emerging data with regards to that.
Absolutely, absolutely. And actually, that gives like a clear picture also, how evolution, precision medicine is actually shaping the entire treatment decision overall for doctors also. So that one question that is stays persistent is what are the main challenges in tackling platinum resistant ovarian cancer and what novel strategies are emerging?
Yeah. So again, as I told you, there are these those cancers which relapse within 6 months of the last chemotherapy after the primary treatment are called as platinum resistant. 6 to 12 months are borderline. So these are the those kind of patients who actually pose a little bit of difficulty for us than treating. So generally, we as a surgeon. Yeah, I'll do a good surgery. It was an optimal cytoreduction. did well. Uh, that may or may not have given HIPEC. Generally, sometimes we do, sometimes based on the affordability, availability, training, and all, we may. I mean, some people might not do so, whatever. After that, yeah, patient is also fine. They have like spent so much, and once they've you know, they're in period, they're all good, they're doing well, so they're all happy. But on suddenly when back, so that is when it is very much awful. I mean, for the patients, like they're very stressed out. So that is the a time when generally you also involve medical oncologists, because they are the ones who have multiple different lines of treatment. Because generally such kind of patients are not very amenable for the same chemotherapy being re-challenged. So generally we are forced to try second line chemotherapies. Sometimes, like initially, when we use paclitaxel and carboplatin, which are the commonest chemotherapeutic agents that we use in the first line, we may have to change it out. Like we may not use a platinum again. We may use something like liposomal doxorubicin, or sometimes a gemcitabine plus another carboplatin combination. So depends on the medical oncologist. So we generally the medical oncologist does look into their data, and they start a second line chemotherapy. Again, after that, again, when they relapse is something which matters. So now in terms of recent advances, like I mean to say, there are situations wherein, again, if we try to do a HID, and sometimes if they're positive, there are patients of mine who were HID negative then, but who are HID positive now. Sometimes in that case, again, we can use an olaparib, that is a PARP inhibitor, or niraparib, rucaparib, whatever. So we can try to use that based on the availability and affordability as a maintenance therapy, of course, not as a primary. Primary will be a second line chemotherapy. And sometimes in patients, it's a recurrent ascites. In certain select patients, especially after multiple lines of chemotherapy have failed. So that is when we select certain patients for PIPAC, that is pressurized intraperitoneal aerosolized chemotherapy, because there is data that in platinum resistant, because of the improved penetrability of chemotherapy when given in an aerosol form, transperitoneally, they tend to improve the quality of life. That was the main reason why how PIPAC actually came out. So mainly for the quality of life is what it came out. So yeah, along with the quality of life, now there are studies which also show some regression. So yeah, we are still in the phase wherein we need to find out data for PIPAC. But yes, the mainstay would be second line chemotherapy plus or minus targeted therapies. I mean to say, like PARP inhibitors or PIPAC in select patients only.
Correct. So, Dr. PIPAC is suggested only after failed HIPEC and PARP surgeries, right?
Yeah, as of now, that's what we have the current data for. In upfront, PIPAC they're not doing, but there are certain, a few colleagues, I mean to say, friend of mine in France, that they're doing a study of a neoadjuvant PIPAC, wherein they give PIPAC initially, in the first line itself. They try to, do give few cycles of PIPAC and then do a surgery. So there are trials underway. As of now, it is mainly in the recurrent setting, failed chemotherapy, and certain select indications.
Okay, got it. So now, doctor, what is the current evidence supporting immunotherapy, and which subsets of patients are most likely to benefit from it?
The those are the patients, especially they should be good performance status. That is the generally they should be uh, usually young patients with well preserved status in terms of not having too many comorbidities. Number one, and good effort tolerance, and things like that, and most importantly, they should not be in intestinal obstruction. So if there is an intestinal obstruction, I mean, like there are usually patients with recurrent ovarian cancer, one of the common presenting features is intestinal obstruction. Now, wherein if they have it, then PIPAC is not a good idea. So we don't have a proper idea, I mean, proper data for that. And next thing is, yes, platinum sensitive, also platinum resistant. Also, we have, it has been tried, and still there is emerging evidence for, incorporation of PIPAC earlier as well, slowly. As I told you, it's mainly the select, the conditions are still a bit selects, we need to be a bit selective.
Correct, correct. So also I feel that immunotherapy also holds a tremendous potential in personalizing care. Correct me if I'm wrong, doctor there.
Yeah, I mean, for certain cancers, yes. For ovarian cancer, as such, still we do not have strong evidence. There are people who are trying CAR T cell therapy, etc. But it's off-label kind. That's all at this juncture. Yeah, because we still have a decent a line of chemotherapies when it relapses. Uh, yeah, but definitely that's how the future keeps evolving. So you have evidence, but over a period of time, you may start getting like good evidence. So it all depends on those research data.
So good that you were talking about that because my next question was what breakthroughs do you foresee in the next 5 to 10 years for advanced ovarian cancer management?
Yeah, so this is something which is pretty interesting. Like there have been like newer things such as for surgically, there have been like something called as immunofluorescence guided surgery, wherein we inject a dye like ICG and try to find out where is the maximum pickup. But again, there are no strict controlled studies that have happened. It's only few institutional experiences as well. What is there? Apart from that, there is like even emerging role of HIFU, that is high frequency ultrasound. In certain places they might have tried, and I personally also am actually into an innovation wherein I'm unable. I mean, I'm not in a position to disclose it, but yes, we are there into some kind of a sensor. And I'm into innovation of that, which will be we will be starting some planning to have some animal studies as well, and then launch it down the line. But yes, planning for we are ready for the patenting. So once that also, these are all basically surgically, which helps the surgeon to uh, achieve a complete site reduction. That's what is very important. And if not, future research, as I told you, will be molecular studies. Like we do have a lot of data for the existing, like PARP inhibitors. All they also came out of nowhere. So and I'm sure that down the line, even for platinum-resistant cancers, we will be having. You never know, like the rate at which oncology research is progressing. You just have a recently Russian vaccine, which is like they're claiming to have a fantastic. They're claiming to have a uh, fantastic results. So like that, I'm sure like things will be coming up because researchers won't stop.
And especially the coming decade, it's like such a huge innovation that are gonna happen.
Absolutely. So the rate at which, especially now with AI coming in, so I'm telling you, like it's gonna take. If you see the growth in the last 10 years has been like this, with AI, it will just go like that because that is the amount of potential it has because it lessens a lot of our effort in terms of the data management and it can give insights like this, especially when the properly done more than the generative AI. So we just have to utilize AI in the right way. Oh, great help. Just seeing so much of AI. I have another project for cervical cancer detection also, wherein I'm utilizing AI for that. So that will also be created shortly. So like that, I'm sure that now the time has come that doctors not just have to, be in their traditional roles of operating in the theaters or just consulting in their OPDs. Yeah, so they will have to upscale themselves, and probably I have been very fortunate wherein I have traveled a lot of places, and all my stint with the Europeans and other wonderful teachers and mentors across the globe have actually shaped and they give us a lot of, especially when you're passionate about something. For me, like I'm very passionate about ovarian cancer, so you tend to innovate, you tend to improvise, you tend to evolve, and I'm constantly evolving. I would say that, yeah, whatever we have learned, but still you are constantly evolving. Want to get that best result out of my patients. So this is all what finally I can do it.
Definitely. Definitely. And I think you were right. You said that evolution is very necessary and acceptance and also AI is actually the future of healthcare, I would
Yeah,
say.
yeah, absolutely. Definitely, because I'm sure that it will, as I told you, it needs, so it's a better way of looking at it, wherein when we look at AI as something totally foreign, and we allow somebody else to take AI, I mean, somebody doing only AI to help us, maybe that only. We also have to learn someday of it, and they also will be using a bit of
Adaptability is also very necessary.
so this kind of amalgamation, this kind of association is something which will happen, I'm sure, very strongly in the near future. And yeah, we will have better things coming up.
Sure, sure. And also, Bhavya, I really like your styles also, so I'll be looking forward to it while I read it. So, Dr.
Oh, thank you so much. I mean, it's always a pleasure sharing knowledge, and especially it's always the questions that you pose itself. That shows the quality of your background search, and so that's something which is very important. I appreciate for any podcaster. Something that's very essential, that the background of that particular topic. So and happy.
I feel like staying up to date is very necessary in any field and in any background. It's really necessary, as you also mentioned. So, Doctor, as we wrap up today's session, thank you so much for sharing your expertise and perspectives with us today on ovarian cancer. And actually, I have also learned so much beyond and the advances that are happening in ovarian cancer. So, thank you for sharing the evolving treatment landscape in the ovarian cancer field.
Thank you so much, Mr. PG and MedSynapse. Anytime, it's always love to share our knowledge, and that's how I think jnana is something which is transcendental, which comes from one generation to the other. It has to keep on passing, and the more you give, the better humanity you see eventually. That's the final thing of it. All when it's all for the benefit of our bacons.
Definitely, definitely. That's like a really good point that you've mentioned, Doctor, there. And I'm sure that our audience of healthcare professionals will also gain a lot from today's episode. And to our listeners, thank you for tuning in and stay connected with MedSynapse. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's like a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay safe and keep learning in this field.